Suffolk CCG, and with Mark Easton, he's Programme Director for our Healthier South East London. I've asked Mark to give a programme update at this stage of the programme. To be clear, Mark is working with us, but equally across the 6 boroughs of South East London, the other 5 being Bromley, Bexley, Greenwich, Lambeth and Lewisham, as I'm sure you're aware. And just in terms of the other pack, there's nothing new in this pack, but we're aware that we've given you quite a wad of papers, so hopefully for brevity, but also so we can get into the discussion, I was going to ask Mark just to speak to this shorter version.
Thank you. So you've obviously been given quite a lot of detail, and I thought what would be helpful is me just speaking pretty briefly, just covering some of the main points. So I think there's kind of 5 points really that I just wanted to make sure that I covered. Firstly, like all strategies, this looks at where we are now and where we need to get to over the next 5 years. And the NHS in South East London is good and well regarded, but it could be better. So we need to have more emphasis on prevention, better ways of keeping people out of hospital, making sure that care is both accessible and joined up. And what we want to do is shift the focus of care so people feel better supported to keep healthy, and we manage long-term conditions better. We also need to make sure we eliminate variation in care, make it joined up, and ensure that we spend the 4 billion of NHS resources we have in South East London as wisely as possible. You'll see that on slide 5 we've developed 6 models of care and priority areas. These have been developed through a clinically led process, and the groups that we've established seek to identify best practice in those 6 areas: community-based care, maternity, children, urgent and emergency, cancer, and planned care. What binds these services together is the structure we've described as our local care networks, and the preceding slide 4 is a rather complicated graphic which attempts to show how the system comes together. So local care networks are where an extended range of primary and community cares are delivered in local areas. Now, I guess we're all conscious that demand for healthcare, particularly hospital care, has increased year on year. And what we intend to do by adopting these models is essentially to stem that increase. So we're not saying that activity in hospitals will reduce. We're just saying it won't get any higher if our plans to improve primary and community care come about. And if we don't stop the increase, we'll effectively end up needing to build another hospital in South East London. And clearly we don't have the resources and the staff for that. That is essentially what slide 6 says. Now, much of the strategy can and will be done on a borough basis, but there are some issues, particularly in respect of specialist services that cross borough boundaries. And that's why, as well as doing work on a borough basis, we also need to work across South East London. And similarly, much of this work is improvement and expansion of community-based services, and this work is, broadly non-controversial and accepted as good practice and can simply be progressed because a lot of it is about expanding access to community and primary care. There will be some areas, however, where we do need to appraise different options of how services might be delivered, and if that results in substantial change, we may need a formal public consultation. It's for that reason that we've raised the suggestion that a joint overview of the Scrutiny Committee might be needed, and that's so we can develop and discuss these issues with one collectively rather than 6 borough-based groups. We have talked about this with officers, and I believe it's under consideration. So we weren't expecting any kind of decision on that today, but we do know it's an issue that's around that needs to be thought about. I think probably all I need to say by way of introduction. I'm very happy to take questions or any comments that you've got.
Thank you, Mark. I should say, for the benefit of the committee, and Shelley, correct me if I'm wrong, that we're going to have a discussion about the joint OSC at the next overview and scrutiny meeting on the 20th of October. That's right, isn't it? So then we can have a discussion about how we take it forward as well as the council. So I had a couple of questions to start, and then feel free to jump in. Have we got to the point where we know what issues we need to be looking at in a joint context, and are you aware of kind of what will already need to come kind of to this committee, and are there specific things that you want us to be thinking about in the coming months?
Shall I answer that? So we've established 4 areas that we are looking at as potential areas for option development. It doesn't mean they will all go through to the process of public consultation, but it means there are areas that we think we need to explore in depth, and through that process, as options may emerge by the time we get to Christmas time. Those 4 areas are urgent and emergency care, maternity, children's care, and planned care. And I think there are different levels of probability that options may arise in each of those groups. If we just spend a moment on the planned care group, a proposal that's come forward is that we might develop an orthopaedic elective care centre. So we would bring together the current orthopaedic elective services that are dispersed across several hospitals into 1 or 2 centres. The idea of that is that would enable that work to be done in protected ring-fenced beds, so they wouldn't be subject to cancellation. And in that way, we'd have much more certainty of getting through the work, helping us meet waiting list standards, and there's quite a lot of evidence that you can improve efficiency and quality in that way. Well, clearly, if that proposal developed, then that's the kind of thing that eventually probably would be subject to some kind of option appraisal and consultation.
Okay. And then my other question was, how are we working with the hospitals, so specifically with Kings and Guy's, on any programmes of work that they might also be doing that fit into those 4 categories, so that we don't get bits kind of 2 streams of activity running at the same time that are kind of being looked at?
So we have a partnership group, which is all the local stakeholders, including the hospitals, the local authorities, public representatives. We've also now something called the executives group of the partnership, which is the CCG chief officers and the hospital chief executives. And that's the group where we talk in detail about the kind of developments that are coming through these 4 groups. So we do know, for example, that some hospitals already have thoughts on how they might develop their elective services, and we're making sure we capture those and understand them as part of our work.
Just sort of a supplementary, which is away from the programme, but probably worthy of note, and indeed it will play out. I'm quite certain that away from the programme there are those areas of care that King's Health Partners, so Guy's, Kings and Slam, for example, locally may come forward and have proposals. I think using the groups that Mark's described in our existing relationships, it's not instead of, it is alongside our responsibility as local commissioners to ensure we bring those to the attention of this committee. And I think that particularly for Kings, you'll be aware that they have a substantial programme of change, and where those things sit outside of this programme, then it will presumably be down to me and the Southern governing body to make sure that we coordinate that process. And the nature of the system for other areas of care is just as wide-ranging, given the King's take, for example, is across London and England for some services. So that duty would reside and fall with ourselves at the CCG.
Okay, thanks, Andrew. David?
Yeah, my question was, it talks about, I think it's on page 6 at the top, about the services based in acute hospitals wanting to meet the London quality standards, and that a piece of analysis is currently being undertaken, which was due to be completed by September. My question is, has that piece of work been completed?
Yes, and it fed through to the 4 groups I mentioned that we're developing more detailed work, which could potentially lead to an options appraisal process. Okay. And sort of a related question. I mean, in regards to, it also talks about how you don't expect for any hospital services to close, or any hospitals to close. But presumably, with this shift into more sort of care in the community, in a sense, presumably not. That doesn't mean that some certain services won't be reconfigured or closed, presumably. Well, what we know through our modelling work is that the amount of hospital activity will remain broadly consistent. So, for example, we know the amount of activity going into our accident and emergency departments won't drop over the next 5 years. So there is certainly sufficient activity for example, to keep all our accident and emergency departments going. That doesn't mean that the pathways within those accident and emergency departments won't change, because we'd be keen on getting things like a single front door, single access through 111, better access into primary care services. But that's largely about stemming the increase in activity. So services...
Don't we, to some extent, have to change the way we work to make the savings as well? I thought we wanted to try to shift money away from the acutes more into primary care. So, I mean, doesn't that require some reconfiguration of services or merging of services or different ways of working, presumably?
Yeah, so I mean the changes that we make through the strategy will have a financial impact on providers. Some of the financial impact will actually be to help providers better meet their cost improvement targets. So, for example, we think there are changes that, planned care is a good example of one where there is some potential benefit to the providers in handling their elective caseload more efficiently. The kind of activity that will be taken out of hospital is the kind of activity which shouldn't really be there. And clearly it's more efficient to provide that in community settings than it is in hospital settings. And similarly, we know there are people in hospital now, sometimes with protected lengths of stays, that actually are better off being cared for outside the hospital setting.
Just one point, does that mean their share of the cake there will be the same, or will they get? Or are you trying to force down the share of the cake that the acutes?
I don't know if it helps at all on page 3 of your pack, and I'm not sure if we speak to it in this slide pack, but certainly page 7 of your pack. We do make reference to the growth in available resource. It's just unfortunately the demands and the associated costs with that will outstrip that. So I think where we are spending additional monies in future years, we're seeking to drive best value for that. And I guess the proposition put forward in the paper is that new money is best spent on preventative services, and our working assumption through the modelling is that community-based care will provide we tend not to talk about sort of a simple lower cost equation, but a better value equation. So will we get more from the money that is spent? So we are trying to do that equation in our consolidated strategy, which we put out earlier in the year. It does give a good deal more detail than we've put in the pack here. It's quite a weighty document, but I think it helpfully gives a do-nothing scenario and then shows the movements in activity and otherwise to shine a light on what would happen if we weren't able to do that. And that's where Mark's suggestion, which I support obviously, that might amount to another hospital in terms of the growth in beds, would not be a sensible thing to do. So our equation is to make sure that additional money does in effect broaden the piece of the extended pie to community-based care. We're careful to say community-based care because it isn't just primary care or just general practice. Our community-based care model extends into social care as well.
Jasmine?
Just a couple of points really. I just was looking at the map that you provided. I was thinking about the transitions of children into adulthood and mental health, and the chart shows us that mental health is embedded throughout the whole system in this model. But I just wondered, how, because that still seems to be an area where people have failed, and I'm just wondering how the strategy will deal with the transition of children into adulthood when they're in receipt of mental health services. So that was one, and then I had another. Okay, and then the other one was looking at the issue that what we're trying to while we're developing the strategy, too many people live with preventable ill health or die too early. And then later on in the bundle, we're looking at the issue of people living longer. So I was wondering how we were getting on with the equalities work, because I know that you've been doing equalities analysis, and that's been carried out this summer, and I just wondered if you could give us a heads up onto how that will impact on this wider strategy. So that's two: mental health, transitions, and equalities.
So if you look at the 6 models on page 5, you'll see that under children and young people there is a reference to the need to do some work to support the transition to adult services. So that's on the work programme of the children and young people's group, and they're in the process of devising their delivery plan. So when that's ready in the next month or two, I'll give some detail about how they're going to approach that subject. So it's kind of work in process at the moment. We have had an equality assessment published. Clearly at the moment, before there's a large number of specific proposals, it's largely around the scope and process of the strategy rather than outcomes at this stage. So it's raised a number of recommendations that we've sent to our equalities working group. We've said that we'll commission another equality assessment a few months down the track when there are more specific service proposals, because I think that's the point at which it becomes a bit more real. And you can get a stronger sense of what we're trying to do with this strategy is, of course, address and tackle inequalities, not exacerbate them. So part of the disciplinary process will be making sure that we commission reports that guide us so that we're going in the right direction.
Yeah, and that's obviously the nub of it, because we seem to be up to our eyeballs in evidence. So, I would have thought that that would have been in there quite early, really. But, I take your point. And just on the first answer, do you think, well, I suppose that will be the acid test for this strategy, won't it? If we're looking at transitions from the children's team, is that enough, really? If we're just giving it to one area, because there's also the adult, the joined up.
Yeah. So, I mean, one of the challenges for all these groups is that they mustn't operate in a silo.
Yeah.
So quite a lot of our work is actually networking them together. So there's a very strong relationship, for example, between urgent and emergency and community-based care, because it's the development in community-based care that's going to make the difference in urgent care. So we've been quite careful to make the connections and to make sure there's a dialogue between the two groups, and where there's a kind of codependency, they're well cited on that and have got a way of dealing with it.
Okay, thank you very much.
Wonderful. Unless anyone else has got any other questions. Oh, Lucas.
Hi there, sorry. In your highlights for the next phase, could you just remind me, please, what you talk about deliberative events will be held in each way. What's a deliberative event?
Do you want to describe the one that was in Southwark?
I mean, essentially, we the ones we've had and the ones we will continue to have got together local residents. I think the one in Southwark. When we were there, David, we would certainly been at one of our deliberative events. But anyway, our most recent
Cambridge House, obviously.
Yeah, Cambridge. Happen to have been in Cambridge House. We attracted in Southwark, I think, about 120 residents, and we've taken an opportunity. Essentially, this has been and will continue to be an iterative strategy to some degree. So we took that opportunity to talk through in some detail each of the care models, to understand people's aspirations for the local services they receive. We're very cognizant of the fact that we're describing our Healthier South East London, but we're actually talking about very, very local service delivery. So we've replicated those discussions with residents, which we've held in big and small groups, actually for the last 18 months, 2 years, in each borough. We've taken that opportunity then to bring some of the clinical leaders and others who've been working on the clinical groups to describe them and to get a better understanding of people's aspirations for them. I guess the best thing from the last one for me is I didn't recognise anyone in the room, so that's no offence to all the people that I recognise, but we were able to draw in a large cross-section of the community and get people's views that we don't often hear. We have engaged, and you have to remind me of the organisation, we have also engaged people who are more experts than us, dare I say, in terms of generating those conversations, so we don't have a professional-led conversation, but one that tries to get into what people are looking for, way of outcomes and how they experience health and social care in the borough.
Bill had a quick point.
So a deliberative event, a deliberative event is a focus group, only just very large.
I've just never heard that term before.
No, neither have I. It's just jargon.
I'm sure you have, and if I agree with you, we'll probably really upset and insult people who do deliberative events, but I'm not sure of the exact difference. No.
There isn't one. It's a focus group.
I'm sure there is a difference.
It sounds positive. I just didn't.
Yeah.
Jasmine, do you have a very small point?
Those events, you had residents there and
That's right.
service users. You may want to share your methods then if they were so successful, because I know elsewhere we've had events, focus groups, but not drawn in as many people, i.e. for our autism strategy, that was used the same venue, but we got quite a poor turnout.
So I think what makes these events a success, we employed a company that takes a demographic slice of the local area. So they actually go out and actively recruit a group of people who match the borough profile by age, gender, ethnicity, all that sort of stuff. So you end up with a room of people which is representative, and often that comes as a bit of a surprise, because what you realise there's a lot of young people in London, and you don't normally get young people at those kind of events.
I should say those the ones we've had are written up in some detail, both as a pan South East London level and for each borough. So we've got some quite rich input into the strategy, and we'll continue to do that.
Well, we'll come back to you on more lessons from that.
And then Paul, did you have a final question?
Yeah, it's a pretty fundamental question, but I struggle at points when I was reading the report and looking at the areas in which you've decided to focus, as to why an organisation or a grouping like yours is the right grouping to do it with. I mean, there seems to be, for instance, when you're talking about deliberative events or whatever they are in Southwark, we're sort of hyper-localising and talking about Southwark issues, Southwark experience for Southwark residents. And I'm unclear, okay, there's going to be some overlap on the borders of the borough in terms of the care received in those and where authorities are working together. But the relationship between these people and Bexley seems to be a little peculiar. I'm not quite. I suppose what I'm asking is for the questions that you're raising in this document, can we be confident that such a large and arbitrary group of organisations such as yourselves is the right forum to go through with it, or is it just another layer of bureaucracy? I'm a bit confused as to why this grouping of South East London organisations are so lumped together. Should we be better doing something with boroughs in our immediacy, or indeed other groups? At a time when we've got an awful lot of cuts facing us, and there's an awful lot of consultative stuff going on, and indeed necessitating working across organisations because of budgetary need, is all of this really necessary?
That's a pretty fundamental question. I guess our view would be in South East London. There's obviously a lot of work which is very locally focused, but South East London does exist as a system, and South East London is a particular geography which seems to have endured a number of administrative reorganisations because it reflects patterns of education, employment and health that actually seem to have survived quite a few years. So people from Bexley may well be coming into Southwark for treatment and care. I suspect the flow in the other direction is much more limited. But we have a lot of specialised services across South East London which attract people from a wide area. Now, I guess you could argue to some extent all of these boundaries end up being arbitrary. We used to have a South London Health Authority. We used to have a single London Strategic Health Authority. So there's always, to some extent, an argument about the appropriate geography. But what we try and do in this programme is get the balance right between what the work we need to do on a local borough basis and that work which really can only be sensibly done on a South East London sub-regional basis. There are other programmes of work actually that are taking place on a London-wide basis for very specialised services. So it's a completely fair challenge, but we still think there's value in working across.
And you think that the primary issues that you've identified here, these are sub-regional issues, not regional issues, not local issues, these are sub-regional issues?
Andrew will comment, but there's actually most of the work that's being done on community and primary care will have a very local focus. But there are still expectations that there are common standards across South East London. So our mantra is sort of common standards, local delivery. And I guess what you're trying to do is work across multiple frameworks, because in primary care, for example, there are 17 primary care standards for London, and we talk in hospital care about the London quality standards. So you actually have to work across a very local focus, a sub-regional focus, a London regional focus, and in some cases a national focus. There's a whole series of national requirements and standards as well. So it is complex, but that's the world we operate in.
And should you?
Oh no, so I entirely agree with that. I guess it is just factually the case in terms of if you took Kings for example, the patient flows for two reasons are right across this region. One is the acquisition of the PRU, which means that there are we have reason to look at this particular geography that we were talking about. It so happens that we have significant and very significant flows between all of those outer boroughs and our local, very local services. I was reflecting with Mark, it is a very fair challenge because there's not much export from this borough. Residents tend to go here, but I can absolutely and categorically say that if we're not able to understand the overall impact on some of our local institutions by the income they receive outside of this borough, so this CCG makes up about 11% of Kings, we take that example of their income. A vast majority of that income is coming from South East London, so we very quickly get into those discussions on a regional basis. So I think they are highly relevant. I guess the other thing to say is we put forward these. I wouldn't like you to go away with the impression that these aren't in natural fact tiered. So there are aspects of cancer which are having to be considered at London level. There are aspects of cancer that are having to be considered at this regional level, and absolutely right down into each general practice and what they're doing with their registered population to make sure they're looked after. The community-based care bit, it is an unusual one because in truth there are 6 separate strategies. Southwark has a community-based care strategy. When we are talking to Denmark Hill Guys and St Thomas's, we do need to be able to tell them what is the collective impact of those strategies and how will they be able to interact with them, given that they are one institution working with many boroughs. So that is a bit of a unique feature of this, but I'd argue that unless we can understand its collective impact, if I exaggerate to make the point, if we perfect community-based care here in Southwark, but Lambeth makes a far lesser impact, then that won't make a huge difference to Guys and St Thomas's cost base or the way in which they're able to deliver services, because there's no part of Guys and St Thomas's that is the Lambeth part, if you see what I mean. So for those reasons, we are tending to consider these things together. Just because it is dear to my heart, the Southwark community-based care strategy absolutely stands alone. It is what we want to do for residents. It's very locally focused, but we understand explaining its impact with other boroughs is important for our partners.
Satisfied, Paul? Okay. Unless anyone's got any other questions, I will let you both go. Thank you very much. And we'll keep you updated about the discussions at OSC on the 20th as well.
Thank you.